opportunity to provide these services to our people and stuff like that. So that's great to have an opportunity like this. So when we start getting more in depth in this, this is a great opportunity for us as from a program standpoint as well as the design standpoint. We just want to engage with y'all so we make sure that we have the opportunity to provide the best services to y'all and the community that we serve. So this is a great opportunity. So what we'll do is I ask our head chief, Pat Leadenfox, to open up with a prayer and allow him to bless this day, and then we'll go ahead and get started.
Father, Lord, again, I thank you for this day. Lord, I thank you for all the folks that are here. Lord, I ask you to bless them, taking time out of their lives, God, to be here. Lord, I just praise your name for all the blessings you've given to our tribe here. Lord, the continued blessings that's going to be bestowed upon us. Lord, again, we meet here, half of this facility, Lord, that's going to be built. It's asking, desperately needed around here to see all the folks, Lord, that are addicted, mental health issues that they're going through. Father, with this facility here being built, Lord, just helping them, through you, lifting all these folks up that have to deal with this sickness that's here. Lord, those ones that are taking part in building this, Lord, just ask that you bless them, bless us through the fruition, seeing this through. And when it's done, Lord, we're going to give you all the praise and glory because we're asking you for this. We know you're going to give it to us. We're saying this all in Jesus' name. Amen.
Thank you. So what we'll do is we'll do an introduction with us, but also what I provided, you'll see some note cards, some pens, and things like that. What we want to do is have an engaging meeting. So if there's any questions while we're going through our presentation, y'all want to raise your hand just to get more clarity or just ask any questions about what we're talking about. Feel free to do that anytime. But at the same time, what we did also is we provided these note cards and pens. So if it's just something that you want to address on more of a private level, we have a box back there so you can write down your questions or concerns or whatever it may be. Please feel free to write down on any of those note cards and just drop them off in the box, and we'll make sure that we, get those answers addressed and things like that, because we know with this it could be a sensitive topic and things like that when we start diving in it. So we just want to have that opportunity for y'all to provide those questions so we can make sure we get those things answered. So that's why you see those pens and note cards on the table. First and foremost, my name is Brian Kirk. I'm an enrolled tribal member of Citizen Potawatomi Nation. My native name is Wabjijak. It means whooping crane or white crane. I've been here at Pawnee Nation since 2016. We started this project back in late 2018, where we just started looking at a feasibility study and looking at things that see if it was viable to have a treatment. Was it something of need, or is it something that we wanted to definitely do here? Well, in 2022, we got to the point that it was a huge need, as well as it was something that would be beneficial not only to the Pawnee Nation, but the communities that we would serve. So we're here today just to get input from the community, not just this meeting. We'll have multiple meetings as we get further, especially through the construction phase and the programming development, as well as in the design phase of it. So this is just a way for us to engage and just get y'all's input and allow y'all to understand what we're doing and see if there's anything that we can answer or incorporate in our facility. So that's me. I'll pass it off to Chris so he can introduce himself.
Good morning. I'm excited to be here, and it's really cool to be able to watch this project come together. You know, I was talking with Brian earlier in the week, and it's really neat to be able to have the opportunity to kind of share about all the exciting stuff that we've been doing really over the past year around the project, and then get community input. My name is Chris Watrous. Just a little bit of background on myself. I'm a clinical social worker and addiction counselor. I've been working in human services for a little over 22 years now. Really the past 12 years, I've been primarily working in substance use disorder treatment and mental health treatment. I've worked in direct care, supervising programs, leading programs, and developing programs. Probably my biggest achievement worth noting is I helped develop the addiction medicine program and chronic pain approach to the largest federally qualified health center here in our country. So that was an exciting process. So glad to be here, excited to be a part of this project. I've got experience when I worked with the health center out in Washington State, working with other tribes up in the Pacific Northwest, including Lummi, the Swinomish, and the Stillaguamish, and more recently working with Seattle Indian Health Board, helping to develop their intensive outpatient program that really integrated traditional Indian medicine into their outpatient program. So again, very excited to be here. Very grateful for folks coming out here this morning on their Saturday to come and hang out with us for the next couple of hours and listen to us speak and ask questions too. So thank you. So this is just a brief outline of what we're going to kind of be going through here today. I'm going to be talking a little bit about the project history, where we're at, and then an opportunity for questions and answers and next steps around the project. As Brian said, I want to reiterate, please stop and ask questions as we go throughout this process. Sometimes as I get anxious, I speak really quickly, or my southern vernacular. So stop and ask me if something's not making sense, and we can help clarify that too. So. I think it's always important when starting out a presentation is why are we here? Why are we looking at this? Why are we having this discussion? And it's hard to miss, you know, people have probably been seeing it in the past several years in the news cycle, all the problems with substance use disorder, particularly around opioids. And it just continues to get worse. You know, I started doing public presentations, you know, talking about the opioid epidemic around 2016. Really, the epidemic was there in 2010 or even before that. You know, I worked in southern Appalachia and western North Carolina, where I ran an opioid treatment program just right outside the eastern band of Cherokee. And we saw it then. Oftentimes the media wasn't really talking about it, or when they were talking about the treatments that we had to offer, it was usually a negative spin on it too. So I think really over the past 6-7 years, as the opioid epidemic has continued to get worse and worse, we're seeing more information about it. When I started doing the community presentations, I think in 2016, and I would go over the overdose death numbers, we were in like 60,000, I think, or so. And then slowly it increased into 70,000. And then it came down for a year, and we got really excited, even though it wasn't really, we shouldn't have gotten excited because those numbers were still increasing in many of our population areas. And then COVID-19 hit, and it was like throwing gasoline on the fire. You know, we jumped from around 78,000 overdose deaths by almost 28%, you know, to well over 100,000 overdose deaths from April of 2021 to April of 2020 to April of 2021. So we've also seen similar increases with mental health issues. I saw some stats coming out of Washington State when I was living there, you know, during the height of the COVID pandemic, that we were seeing, I think over 60% of the population had a diagnosable depression or generalized anxiety issues that were happening related. So again, it's really just been throwing gas on the fire. You know, I've got some numbers behind me as far as the overdose deaths, over 100,000. And that rate of overdose deaths we've seen, there is not.
Yeah, that's about as big.
Good question. Good point. Essentially, what you're seeing there is you're seeing the overdose rates between 2010 and 2020, and you can see the trajectory significantly going up around 2020.
Age adjustment rate.
It is, yes. Sorry, I have to look here. Age-adjusted rate per 100,000. No, that is the, I'm sorry, and I have to look at that. No, there's not 10-year-olds. I would imagine that is the number of overdose deaths that we were seeing those years. I'd have to look at that specifically. Good point, though. Good catch. Good question. And I may have put the wrong graph on there. I know that it increased there. I just see the age-adjusted rate per 100,000 population. So I apologize. I don't know what that data on that is without looking at the resource closer, but I could get that information to you. No, and I appreciate you pointing that out too. What I had intended putting there was a rate of the overdose deaths and showing the increases, but as I read it and look at it, no, we typically aren't seeing 10-year-olds with overdose deaths. So, again, I apologize. That's my putting the graph together, too. No, it's a good question. That's exactly what we want to call me on it. So that's what we want to see. So I will say the rate of overdose deaths among American Indian, Alaskan Natives, we do see that as well above the national average. You know, I did take this from SAMHSA, who is our Substance Abuse, Mental Health, Substance Abuse Administration. Our data figures are usually typically several years behind. Oftentimes we don't see that until 3 or 4 years post. 2019, it was around 350,000 Native American adults identified as having mental health or substance use disorder issues, around 142,000 with substance use disorder age 18 and older, around 260,000 with age 18 or older with mental health. And of those groups, there was about 52,000 that had both a substance use disorder and mental health issue. You know, looking at Oklahoma, Oklahoma has been identified as having a higher prevalence of mental health and lower access to care. It's estimated, and again, these are older numbers, between 700,000 and 950,000 Oklahomans suffer from mental health and a substance use disorder. That ranks Oklahoma as number 3 in the nation for rates of mental health and number 2 in the nation for substance use disorder. And our existing psychiatric and chemical dependency service beds really aren't adequate to really meet the needs of the service area. I was sitting up. Sure. I would say no. In my experience, typically, and most of my work has been around opioid use disorder, and these are old stats, but we would estimate around there's around 2.7 million people that struggle with opioid use disorder in general across the United States. That's jumped from around 2.1 million, and about 5 years ago, our treatment capacity was at about 1.1 million people. You know, so we are severely missing the mark on having access to both mental health and substance use disorder treatment and trying to catch up to meet the demand of it. And I'll tell you, I was up researching late last night and plugging graphs in, and that's probably where I made my mistake on that one. But this is me at 10 o'clock on my Friday night. I found some good graphs, particularly for Oklahoma. This comes out of the Department of Mental Health and Substance Abuse Service Administration. I think these were from 2018. It had a nice little state map. This is for untreated mental health and substance use disorder here in Oklahoma, and I really zoned in and took the snapshot of the counties surrounding Pawnee here. And I don't know if you can see those rates up there on the board, but they're pretty high. The one on the left is for mental health, you know, and they're in the upper 80 to 90% as far as untreated folks with mental health issues. It goes even higher on the one on the right for those with substance use disorder issues as far as into the 90%. I went a step further and looked at our youth. It's a little bit better in terms of mental health. as far as those that are untreated, but if you look towards substance use disorder, those numbers are really even higher than the adults from what we're seeing too. So, yes. That's correct. So as we look at and we'll probably hit on it here in a little bit in the presentation, but the residential facility will be serving, we'll be looking at this region, the 5 surrounding counties, but honestly, because there's such shortages of services, there's probably going to be folks from all over the state that will be coming to the residential program. Your outpatient program is probably going to draw more locally. You know, folks like an intensive outpatient program that might meet 3 or 4 times a week, and I go home, they might not drive an hour to treatment necessarily. So that's probably going to pull more locally from the county in general, if that makes sense. Any questions or comments on any of those stats? President?
I'd just say that this data is very eye-opening. You know, I always have a feeling that, you know, that it's problem with that data really shows there's a big gap in our mental health care here. So this project is really going to be filling an important gap in our medical system. Very glad that the work that you've done.
Thank you for that comment. And it was eye-opening to me. I knew there was a problem when I came up with these maps last night when I was looking at the Oklahoma Department of Mental Health and added those in. I was kind of shocked as far as the amount. And I'll tell you, it's not really unique just to this region either. Oklahoma in general, looking at the entire state, is very similar to these grids that you see here with lack of access to services, both mental health and substance use disorder.
How come Oklahoma is so high in mental health problems? I knew that it was a crazy state. I mean, I had no idea.
I don't know.
Wouldn't it be,
You want to add something?
Like I said, this several times before, but I think it's worth saying again that on the same lines, I used to do a significant amount of emergency room work. And what they, again, it's not an uncommon thing that somebody again needs inpatient site care. Whether it's substance abuse or they're just psychotic. And it would take hours to find a bed. And when we found one, we're having to send them all the way across the state. There is nothing in this part of the state. And a couple of them that are, again, on the other side of Tulsa, in Tulsa and the other side of Tulsa, you know, that are often full. It's just a tough situation, and the point being there is a huge need. And you know, it's a great thing that we have this situation where we're going to be able to, there is a real need there. This is something that should be amazingly successful. We do good things for our community, in this case, the state.
Do you know if there's any other tribes in Oklahoma that have a similar project going on?
yeah, well, on this magnitude, I don't think so much from a CON standpoint, because what we're doing is unique because we are kind of involved with the state, so we have a better relationship with the state as well as looking at reimbursement rates. But there are some tribes out there that have services, like the Ponca tribe. You know, they have a treatment center, but it's more, most of these larger tribes, you know, like Cherokees, like she mentioned, you know, they're individually ran. So, but at the same time, the need is so big. It increases our way of looking at, you know, providing the services. Like Dr. Evans said, it was like, you know, going back to kind of looking at the things that we saw, because we have a substance abuse program, and one of our biggest hurdles was access to care from a treatment standpoint, because, you know, we had a relationship with the Ponca tribe, and there's some other tribes that we would look at of just reserving a bed, but it wasn't meeting that demand. And if they were full, we would be calling around and sending people out 1, 2, 2.5 hours, if not further, and getting those people access to beds. So that was one of the things that sparked this investigation, you can ask. So what we started looking at was, you know, we did get a grant from SAMHSA or HRSA, which was a rural community opioid response, and that gave us the ability to start looking more in the roots of what was our hurdles, what was our things that we were seeing in our community. Was it individuals getting the help, or was it just lack of access? So that's what we started seeing, was lack of access. You know, once we build this facility, we will be the first one in the state, in the northern central part of Oklahoma. From a CON standpoint, we'd be the first one in our region. So we're going to look at providing access to care that's not here. There's places here that do it more on a private level, you know, and from a physician standpoint that provides, but not from a treatment standpoint, that people need long-term care, you know. So we would be the very first facility here. What makes us kind of unique is providing it access to care, of looking at it from a native standpoint as well as looking from a community standpoint. So what we did was through that grant and looking at that feasibility was, you know, we did bring in regional stakeholders, not just from this region, from Pawnee, but we were looking at bringing in external stakeholders from like Cushing, Osage, and other areas like Noble and Stillwater and stuff like that, and seeing what was the biggest issue that we were facing. So we were able to get a consultant, Lake Behavior, you know, they're out of Florida. But what brought them unique to us was, you know, what they do is they build treatment facilities throughout the nation, you know. So it was a great way for them to collaborate with us and seeing what we could do to provide better access of care. So we were able, at the end of 19, was, you know, build a team, build some plans, look at what we would have to do to get a treatment facility here and, you know, address the people. Because one of the biggest things that we see is not so much access, because there are opportunities that we can send folks out. But when you look at sending folks out, you know, an hour, 2 hours away, you know, they do get the access. But once they, you know, the exiting process of it, you know, they get back, thrown back into their environment, and they don't have the resources to continue that. So it increases relapse. So what's going to be beneficial from this is you not only have that access here from a community standpoint, but the longevity of care. Because, you know, there's things that, you know, they do get that first phase of care, but, you know, then they get thrown back in the environment and they just don't have those resources. Here is like what makes this unique is not only that they're leaving, let's say, the long term, but before they like basically leave the building, they're getting the resources to continue that care on the longevity side of it. So this is what's going to not only be a unique opportunity, we're focusing it from multiple levels, just from an inpatient and outpatient side of things. So that's what's going to make it, I think, a unique opportunity. So what you see here is we know that we have, you know, the IHS clinic, and we've been in numerous conversations with the IHS, and one of the biggest things, not only from our substance abuse program, is also from IHS standpoint, is access to care. So what we wanted to do is address that issue. So what we're looking at is having a facility right across the street from it. Not only that we, from internally addressing the care from our clients, is, you know, have that access from IHS to send folks across the street that are dealing with mental health and substance abuse. So what you hear is just a preliminary drawing oversight of where the facility will be located. what also makes it unique is, it's only a building or so afar from a law enforcement. It's about a block and a half from the community park and things like that. So there's a lot of resources available for individuals going through that process to have that access of getting better and finding their view of prosperity. So this is kind of a little overview. So what we're seeing is looking at what we want. So one of the biggest thing is this facility will be a 26-bed inpatient facility. And it's more of a adult, 18 and plus, male and female, but our outpatient wing will address all ages and both male and female, and address our elders as well. So this will be a 26-bed residential treatment facility with outpatient care. So what we were looking at is not only addressing the Native American perspective of care, but also integrating what would be best for a client. So what we want to integrate in this facility is not only what would be best for the client, but also integrating Western medicine as well as our native customs and things like that. So all tribes have different ways of addressing their native medicines. So if that's through smudging or just talking circles or sweat lodges. So what we were going to do here is do a good way of accessing and assessing our clients what would be best for them. Most of our program services will be client-based, but have the opportunity, if you're native or not native, is finding that niche that will find you to give you opportunity to get over that hurdle. So what we want to do is provide services that are based off the client. So we will have a mixture of Western medicine as well as native customs through our programs. Now, what Chris talked about was looking at that chart. Our chart is based off of the 5 region. We believe that the need is so big, we'll probably get a influx of outreach from individuals outside of our region. So we will be serving Pawnee, Payne, Osage, Noble, and Kay County. But we wouldn't be surprised if we extended out further than that. So kind of just give an update of what we've been doing in the past to where we are now. So back in March of 2020, we were able to file a CON, which is a certification of need through the state. Certification of need, basically, the state looks at it from a standpoint, from a regional aspect of, is there a need for beds? I mean, basically, that's what the CON is. Is there a need for beds? As well as look at it from a market, from a competitive standpoint, is there other people providing those services? So once we looked at that and saw that there was no services here being provided, makes us unique because we would be one of the first to offer that services. So back in March, we started that, and we were able to get our CON from the state. So our state granted that because they saw that there was a huge need, and so we went back to PBC to basically allocate the land that we were looking at, because we felt like having a treatment facility right across the street from IHS here would be beneficial not only to them, to ourselves. So back in May of 2020, they passed a resolution to allocate that land. So in September of 2020, they gave us our first year, and that was basically giving us, the process of where we're at now. So we started, getting the CON and starting the development of it, and then it led to looking at where we need on a financial standpoint of looking at the private and public spectrum. Yes, sir. Yeah, so many states, not Oklahoma, but there's other states that require a CON to even start this endeavor. So CON reviews the access to beds. Certification of need. So it's certification of need. So you got to certify the need. So is there a need? Is there something that we need to address? So what the state looks at is making sure that is there any other people or any other firms providing services in our region? So there's different regions. I believe there's 13 regions in the state of Oklahoma. I think we're region 11. And it covers the 5 counties that we showed earlier. Currently now, there's no one that's registered through the state that's providing those services. So they saw that there is a huge need, which we clearly saw the numbers. And there's a shortage of access of care. So what we did was we filed a certification need through the state of Oklahoma saying we see that there's a need and we want to kind of lock down those beds to provide those services in our region. So we were able to work with the state, and they granted our certification of need because they saw that there was a need. So they were able to provide that certification. So now we're working with the state, and the preliminary studies is basically working with them and letting them know what services we're providing, which we'll talk about a little bit more further. But with that, that basically gave us the opportunity to start moving in the next phase. So now we were looking at the financial standpoint, was looking at where we can create our portfolio, at bringing investors in and getting other financial structure through our grants and funding through the tribe. So what we did was we started soliciting an architect and things like that. So we were able to bring an architect in, as well as looking at a firm that can help us not only develop it from a management standpoint, but have an opportunity to provide equity into this project. So what we did was we sent out a proposal working with our firm, Baker Tilly, and that's how we got in contact with Ascension Recovery Services. So they were able, they saw that what project we were working at, and they were heavily interested in the project that we were working with. So we started building that relationship, and we selected Ascension Recovery Services because they saw what unique opportunity this was, not only just for a standpoint on Native Americans, but just providing access to care in rural communities. So back in July 2020, we started working on that contract, and that's what connected us to Ascension. And I'll pass over to Chris so he can talk about his.
Yeah, and just briefly give you a little bit of background information on Ascension Recovery Services. You know, we've been assisting and providing programs with consultation and supporting and development and implementing and management services of behavioral health treatment centers since about 2016. In that time, we've worked across 30 different states and really considered an industry leader in developing the comprehensive treatment, fully integrated treatment, including substance use disorder and mental health services. You know, I've been working with Ascension Recovery Services a little over a year, and what really drew me to the organization was its mission and its commitment for folks that are struggling with substance use disorder and mental health issues. When in my first week of work, I got to meet our CEO, Doug Leach, and he was very open about his story of recovery and what that process looked like. And I wish I could tell the story because I can't tell it as impactful as he can. The sort of high-level overview that he shares with folks is, you know, addiction pretty much destroyed his life. I mean, took everything away from him, from his work. He lost everything, his health, eventually got incarcerated, and was really at his rock bottom until he realized, I need help. When he had the supports in his life to really help lead him towards treatment, and he lived in West Virginia, there was no treatment around. And so he had the resources to eventually be able to go out of state and get into a really good program, long-term residential program to help him in recovery and sort of build and put his life back together. He came back to West Virginia, and another gap that he saw was, now I'm sober, now I'm out of this residential program, I'm going back into my community, and there's really no supports for me here in this community that I'm going back to. And so he developed a local sober living home. And sober living homes, if you're not familiar with those, they're homes for folks that are in early recovery. They're structured environment. There's other folks that are in early recovery as they're really reintegrating back out into the community. And so that was his first step, I think, with Ascension Recovery Services. And then they started looking at, here in his home state of West Virginia, there was no treatment. He had to go out of state. So we wanted to develop a treatment program there. And so he looked at, how do I develop a treatment program? And there are no guidelines for how to develop a treatment program. They're incredibly complex. And they did a lot of research, and they helped open up a program. And from there, Ascension was really born of, this is something that we want to do. We feel that we can assist folks in having a roadmap to develop a good program in their community. And so we've worked with a lot of different folks and being able to do that, depending. And I will also say that a large majority of the folks that work at Ascension are in long-term recovery. They've been through treatment, and so it's really cool to see that and them advocate for the people that are in treatment and designing programs for people in treatment and by people that have gone through the treatment and recovery process. And so I think that really makes Ascension unique. The slide behind me, it's a little bit busy, but these are the other folks that we've been working with really closely on this project. Not only Ascension Recovery Services, Brian mentioned Baker Tilly. Baker Tilly helped bring us on board. They've also been really helpful in terms of navigating the financial landscape, looking at new market tax credits. I'm not going to even begin to try to explain that because it's so complex, but it's funding opportunities that will help us open this up and sort of navigate those complex waters, and Baker Tilly's been leading that effort. We've been working closely with JBS International. They are also a consulting firm that's worked with a number of tribes. I believe they've worked with Pawnee Nation previously on other projects or other work.
Feasibility study.
Okay, so Brian said they helped with the feasibility study originally too, and so they've been really crucial, helping with our community, getting our community engagement efforts off the ground, making this happen here today, as well as looking at some of our grant initiatives that we'll talk about here in a little bit too. And then we work with Third Horizon Strategies, which is a really cool organization that works really at the macro level across the United States and developing strategies with insurance companies and funding for treatment. And so they've been really helpful navigating, how do we build a sustainable model over the long course. So the next slide is even busier than the previous slide. I'm not going to go through everything, but this is a lot of the experience that the team brings to the table with different projects that they've worked on. I will say with Ascension Recovery Services, we work really closely with the city of Boston in developing a 450,000 square foot facility that was on an island outside of Boston, and really trying to develop that project, which is fascinating, what they were envisioning. We've partnered with Kathy Ireland Worldwide to develop a number of treatment centers across the United States. And we're in the process, I think we've opened 3 facilities with 3 more coming down in the future. And also in 2018, there was a Netflix documentary called Recovery Boys that was a documentary that featured one of our residential treatment, or one of our treatment programs called Jacob's Ladder too. So a lot of experience that we like to bring and share. Let's see, I don't know if this is my slide or not, Brian. I think this one's yours, man.
Okay, so what we're at today is looking at, so we granted a new CON back in December where it's approved. So what we're looking at now is developing the processes. So when we formally started working with Ascension, our it was very complex because this is just one of the little components that we wanted to look at. Because we want to engage the community and make sure that we get their input on services and design and making sure that it's a warming facility, is a welcoming facility. But outside of that, there's a lot of things that's incorporated in that. So we wanted to make sure we started looking at the construction process of it. We wanted to look at the grant opportunities to see if there's any state, federal, or internal funding that can help support this facility. But there's a lot of legal work that is entailed. Is that, working at making sure that working not only with our architects, construction management, or just internal management of running the facility, who would have ownership, and so forth. So there's a lot of work groups that we wanted to make sure that we develop. But then you see there's a general work group, and there's so many different work groups working simultaneously that we wanted to create a general work group because some of those things overlap. There's certain things that we wanted to make sure that we can provide updates and things like that. So when they go back and have their sub-work groups, they will make sure that we're all working together. So there's a lot of different things working and moving at the same time. So this is one of the biggest things that we wanted to create was having that community engagement and provide and inform the community of what we were providing. So one of the biggest things right now where we're at is we started developing our architect design and things like that. So I don't know, if about a month ago or so like that, PBC selected a construction firm, which is Mascot Builders outside of Jinx or outside of Tulsa, and they're located in Jinx. So that's the biggest current firm that we selected. So what they're going to help us is build it and making sure that we start that construction processes. So one of our biggest goals within our certification of need is looking at the licensings and the grant requirements that help us build this facility. So one of the biggest methods that we were able to provide is our understanding our procurement process, not internally with the nation, but also understanding the procurement processes with our federal funding, which is USDA and EDA, which is Economic Development Administration, which they provided us let me backtrack a little bit. So what we did back about a year ago is we provided there was a grant opportunity through EDA, which there was only 2 funding opportunities in the state of Oklahoma, and we were one of the 2. And we got the biggest allocation from the state of Oklahoma at $3 million. And the previous one outside of us only got little less than $1 million. So the state of Oklahoma saw that this was a unique opportunity, so they were able to fund us $3 million to support this program. So there was a lot of press releases, and there was, if you go back and review their website, you can see that that we had a lot of support from senators and congressmen throughout the state that saw that this was a need and a unique opportunity. So they were able to support this, as well as USDA from a regional standpoint. They were able to support us with an additional $1 million to give us funding for the construction process of this. So that's where we're at today, is still ensuring that we develop the budget and make sure that we build this facility. So what we did was we select a firm outside of Tulsa, which is Health Facility Groups. They're very familiar with the certification of need and process, working with the state and understanding what is required, because when it's not just building a facility, you have to have certain things integrated in that facility. Square footage on specific rooms and things that have to be locked down. State requires a lot of things from not just a reimbursement side of it, but just making sure you get your licensings and things like that. There's a lot of requirements. So they are very familiar with that. So they build behavioral health and treatment facilities all throughout the state of Oklahoma, Kansas, and Texas. So they're very familiar of that process. So from our regional feasibility study, we had a preliminary floor plan, which will show you the most current floor plan of where we're at today, because a lot of those requirements, we were able to change those things. So working with HFG led us to the construction firm, Masca Builders, and looking at the requirements throughout the state of Oklahoma. So behind me, you can kind of see the floor plan of this facility. Now, this is outpatient, inpatient, as well as it will have access to emergency care too. So what makes this unique is not only looking at from an inpatient, outpatient, but also looking at from the need from emergency standpoint. So we wanted to make sure when we start looking at phases is making sure that we integrate people that have ability, instead of throwing them in the judicial system, we can have access to people that can just get access to care and not fall through the hardships of just getting in, the jail systems and things like that. So what you see here is our administrative standpoint, our outpatient and inpatient. So this is going to be a unique facility here, and it will provide not only just inpatient, it will have critical access, it will have detox, and have things like that. But again, going back to what I mentioned earlier, is not only when they go through the inpatient phase, before they leave the building, they'll have that outpatient and long-term access of care, so they'll have that outpatient side of things. Now, through that, this will be a great opportunity to make sure that we provide services so they have the best access of integrating in their environment and their community to start that process.
Yeah, and I'm going to back up on that if that's cool with you, Brian. I'm going to, let's go on. There we go. Perfect. Yeah, and I wish this was a little bit clearer. It's hard to do the cut and screenshots, and so it didn't come out as clear. This was at the completion of our schematic design. We've actually updated this a little bit since then because we keep moving forward and adjusting. And everything that Brian just described, we've been working really, really hard probably over the past 6 months, meeting with the architect, really fine-tuning, really looking at the workflow of how an individual enters treatment, depending on the level of care and how the building works and how that happens. We talked earlier, the original plan was around 29,000 square feet. We were able to look at it, and we've cut that down to around 21,200 square feet, give or take a little bit, really just to make sure that the space was optimal, and some of it, was a little larger than needed, which was some cost savings that we'll talk about here in a little bit. I did want to kind of highlight so you can see what's what on that too. The blue in the front part of it, that is the outpatient program. It's counseling offices. We have several group rooms too. We're going to have partitions in between the group rooms where it can open up and move into a larger group room to have a space similar to what we're sitting in now. The thinking is outside of the outpatient clinic hours that it would be open to the community for potentially self-help groups for those that have completed treatment, such as Narcotics Anonymous, Alcoholics Anonymous, or Smart Recovery, to be able to host those, because that's a huge step for folks post-treatment too as well. So the stuff you see in green, that's our kitchen area, and then the dining hall next to it. The red is the administration offices. And then you have the purple down on the left and right wings, which is the inpatient unit that what Brian was describing. On the left-hand side, the smaller side, that is the crisis stabilization side for those that have more acute issues. And we'll talk about services here in a little bit, but we'll have 2 beds in the acute crisis wing. Will have 4 beds in the detox and withdrawal management for folks that are stabilizing as they're coming off of substances that they might be physically dependent on. No. There's so on the crisis side, those are individual rooms, and there's 2 beds total for 2 rooms. On the detox side, it's 2 beds per room, and so there's 2 rooms for a total of 4 individuals that would be able to receive treatment. And then, do what? That is pretty common, yes. 2 to a room typically is what we see. And we made it, at least on the crisis side, because those folks are more acute, being able to have their individual rooms too, so. On the other wing too, on the eastern side of the building, on the right-hand side, that is going to be more of the long-term stay for folks. So folks that have gone through and stabilized through the detox wing, and those are also double occupancy rooms. So we have about 20 individuals, I believe, so 10 rooms total. Getting a little bit of feedback there on the mic. I think that's better now. So really looking in the steps going forward ahead, you know, was there any more questions on the floor plan layout, kind of what we got, or comments? Okay, cool. Looking forward ahead over the next little bit in design development, continuing to work with the architect that Brian was talking about, as well as the construction manager, really from June up until about November. As Brian mentioned, we submitted the stage 1 of the CON to the Department of Health. That's been reviewed, that's been returned to us, and we're working with the architect to amend the comments that they made on it, which is a pretty normal process, and probably we'll have that back to the state in the next, 20 days or so. Oh, no worries. That's me broadcasting live there. As Brian mentioned, we selected the construction manager, and we've got a lot of community engagements efforts underway. We've been working sort of behind the scenes, and Brian will talk a little bit more towards the end of our presentation today about the Community Advisory Committee. We've been trying to get out more social media posts and notifying folks in the community about what's happening and where we're at in that project. And we want to continue that and improve upon that. Really looking at the timeline ahead, design development. When I created this slide, that was the current timeline, which was a couple days ago. That's actually moved out about a week. We have a meeting with the architect next Thursday to complete the design development of the project. And then it'll move on to construction documents as we sort of hit that crossroads of, yep, this is what we want, this is the design of the facility. Then they'll start to solidify that in the construction documents, which should be completed around mid-October or so. And then we review that process between mid-October and November. And I think this one's you, Brian.
So we just want to update the, yes, ma'am. So
Okay.
And Brian May can explain this better. Then it means that we've created the structure of it to be able to give back to the Pawnee Nation. We discussed, and we'll talk about a little bit about our legal work group here in a second, but we went, yes. No, that is actually the entity that the Pawnee Nation has developed under the Pawnee Nation. So we looked at the structures of nonprofit versus for-profit and what was the best for the Pawnee Nation. And we hemmed and hawed and went back and forth and looked at the pros and cons of a for-profit versus a nonprofit. And the for-profit added more opportunities for the, essentially, when the program's up and running, to give money back to the Pawnee Nation, if that makes sense.
So what we did, yeah, so, Pawnee Nation is the sole owner of it. Then you have a wing, which we developed was the Behavioral Health LLC. So it's similar to our TDC, our tribal. Yeah, so it's just another wing that solely just concentrates on this facility. So that's what the LLC is. It's a for-profit entity that will have oversight. So it would have a board. Yes. So Pawnee Nation, the business council is the sole owner of this facility. Currently, now it is at 100% ownership of Pawnee Nation.
help understand.
Yes, just currently, yes. It could, just depending on the investors that we bring up. One of the things, so one of the things that we'll look at investors, it is solely owned by the Pawnee Nation, but if they want to bring in some other investors to help support this project, it could deviate. But currently, right now, where we're at, Pawnee Nation is solely owned and taking lead of this project. So what we've done is created an LLC that has basically a board and have oversight of this facility. And then what will we do is allow that board to make decisions on behalf of the council and making sure that the facility is managed correctly. So that's basically what you'll see with this LLC. So.
Good question. We spent 8 months on that topic, talking about it. Seriously.
Yeah. The board is not, so I think we're going to set up a meeting next week to work with council of selecting that, and it'll go through the normal which I'm glad you mentioned it. So if anyone virtually or in person that wants to be interested of being a board member and things like that, please leave your contact information in the comments as well as in the back, because we will be selecting a board for this facility. And we'll be working with PBC of that selection. So if you're interested, please provide your contact information, and we'll reach back out to you to get that information. So where we're at now and start looking at the future is the construction phase of it. So what Chris mentioned is we're pretty much almost done with our design. Our next big hurdle is the construction process of it. We believe that we're going to start our construction process in November, and that's going to take between 12 to 18 months, given play with weather and things like that. So we look at having this facility. We can build a 22,000 square foot facility in about 12 to 18 months. So we believe that this will be done in about June of 2024. In the meantime, we're going to start this process of continue engaging with the community, but also looking at the program services that we want to provide. So that will make sure that we have our accreditation, we have our licensings, we have our curriculum and so forth, that we have mechanisms working with our colleges and training folks and things like that. Because our biggest thing is also utilizing our colleges and developing that workforce and just kind of having that rotation of developing internally so we can have jobs and things like that available here in our community. So, but also looking at services that will benefit the clients and providing those services. And since there's such a big demand, we will be also marketing this facility, but I think, once people find out that there's a great facility here, that we will get an influx of calls and things like that. So this is just our next phases from where we are today in looking at the construction process of what we'll start moving forward. Okay, so where we're at, just to kind of give and paint a picture of what we've been doing since 2018, is looking at grants and things like that to help support this facility. So what our work group has done in the last year or so, we applied for about over $16 million worth of funding. Currently, we've received $4.2 million, and we expect that with the new market tax credit, which I'll paint a picture. So new market tax credit is almost like looking at rural or economic deprived communities. Is basically investors put in money through that realm that will support development in rural and economic deprived communities. So it's almost like free money, but it's also investor money that's supporting rural communities and things like that. So we are in an opportunity zone that fits that realm. So once we get, due to financing through the banks and things like that, we would be expected to receive $2.2 million to support it. Currently, we have about $11.5 million pending, but what we've received right now is about 4.2 out of our $16 million that we applied for. So what we believe is, when we originally started this project, we looked at that this was basically almost a $17 million facility. We've downsized that to be more efficient and things like that. So the construction side of it was $12.4 million. So startup cost is going to run you about $3.5. Out of that startup cost is going to be the first year of operation, which will get us accredited, get our licenses, so we can go back and have that reimbursement rate, because we won't be able to get that until we have occupancy in our beds. Because the state will have to look at that and making sure that we check all the boxes and making sure that it's a facility that's running based off of their needs. So where we're at right now out of that 3.5 is the 1.7 that you see on the operational costs that would cover that, to making sure that we get our license and things like that. So the total cost of this is going to be about 17 million, a little over 17 million. But what I mentioned earlier is, like, when we started this, we looked at it, this was a $22 million facility based off of the size as well as operational costs. So just looking and working with HFG and Ascension, we've looked at making our facility more efficient. So we've already saved over $5 million of kind of making it more of an efficient facility.
So just briefly, I mentioned a minute ago talking about the legal work group efforts and the for-profit question that came up. And the legal work group, and we've been meeting on a weekly basis really for the past 8 or 9 months now on a number of just different topics and issues, around the complexities. Is this a for-profit or a nonprofit? What are the pros and cons to it? And really vetting all that out. Us at Ascension participating in that call, as well as folks from Pawnee Nation, President Echo Hawk, I know you're involved in that, as well as Attorney General Smith and Brian and folks from Baker Tilly, and really sort of laying those pieces out, the more complex legal questions as we put our heads together. It's also in that process where we review the contracts. So the architect HFG that Brian talked about, we sent out requests for proposals. We looked at those proposals. We looked at those contracts to make sure that it fits the needs of who we're looking for and what we're looking for. The same with the construction manager, and looking at those contracts before we send them to the Pawnee Business Council too. And currently, I think it was mentioned a second ago, looking at in the process and how we're going to form the board of directors for that for-profit LLC that we were talking about. So really just looking at all the legal aspects and most of the stuff that's above my head, and I kind of leave to the attorneys and the experts and give input of and ask the questions. So I want to kind of completely switch gears and talk a little bit about treatment services, and kind of give an outline of what that looks like. And this is a continuing evolving process, and may continue to evolve as we start facility services and even open up. But right now we're looking at, as mentioned, both outpatient and inpatient services. We're looking at incorporating traditional Indian medicine, both in the outpatient and inpatient program, and I'll talk a minute about what that looks like. Outpatient services, we would be providing substance use disorder, what is considered outpatient, as well as intensive outpatient for youth between the ages of 12 and 17, as well as adults. Medication-assisted treatment for opioid use disorder, as well as alcohol use disorder. Peer support services and case management. Peer support services, those who aren't familiar with that, that's sort of exactly what it means. It's typically people that are in recovery and have stabilized in recovery and being able to participate in the recovery process. It can be incredibly helpful as one is going, whether it's inpatient or outpatient treatment, they have a lot of questions. They're unsure about this. They might not feel comfortable going to their counselor. And a lot of times folks will talk to a peer before they'll come to me and talk with a counselor. Or they can hear feedback from a peer and they'll take it in as opposed to hearing it from me as a counselor too. So we found that they're incredibly effective for getting folks to participate in treatment because they've experienced it. They've been through the recovery process. And so we find that as unique and can be really, really helpful to the treatment process too. As we look at inpatient services, we've talked a little bit about it would include your adult residential. It'll have withdrawal management. That's the fancy word for detox services, and there's 2 different levels. Pretty acute patients we'd be able to serve. And then we would have the crisis stabilization for those with more acute psychiatric or co-occurring who have both a substance use disorder or a mental health issue. Yes. That's a good question. So the question was, would we be using evidence-based models in the treatment program? And the answer is yes, absolutely. So as we look at both the residential program and the outpatient treatment programs, we have several good evidence-based models that we incorporate, typically using a combination of group and individual counseling, both for inpatient and outpatient treatment, using evidence-based curriculums. But we also break it up a little bit. So you have the good curriculums, there's Living in Balance, there's the Matrix model, and Ascension has a model that they've developed that uses acceptance and commitment therapy and sort of outlines the classes. But we also have other activities in it, so if I'm coming to an intensive outpatient, the treatment schedule may be this hour I'm doing dialectical behavioral therapy in group. This hour we may be doing CBT, cognitive behavioral therapy techniques. And the last hour, we may just be talking about how my week went and processing and getting that sort of group interaction too. So everything will be evidence-based that we'll be incorporating throughout, as well as the medication-assisted treatment that we'll be providing folks too. So good question. Sure, I will try my best well, and it's just as it says, because we want to make sure that treatments are effective. What am I doing? How do I know that it's effective? And we want to make sure that there's evidence behind it. We don't want to just start something and put somebody in a program and, gosh, this sounds bad, but, doing a exercise class or a yoga, what's the evidence behind that? How do we know that that's effective? And so has it been measured? Has it been looked at? What's the outcomes of that? And so it means it's been scrutinized. Typically SAMHSA, the Substance Abuse Mental Health Services Administration here in the UNS, has their whole list of evidence-based practices. And we want to make sure that any of the treatment programs that we incorporate do have that seal of approval. They have evidence-based. The other issue is too, and I'll get on the soapbox here, is making sure that we're actually facilitating it and holding it to true fidelity, which means that we say we're doing it, how do we know that we're doing it? And that's where we bring in the clinical supervisors and that sort of oversee the clinical process and work closely with the counselors to make sure that it's being implemented to true fidelity and that we are actually providing evidence-based services. Did that answer your question, or was that sort of a roundabout? That's absolutely really right. So, you have a question? Sure.
I've been to 5 treatment programs, and again, they were all different. Tribally ran programs, and I just wanted to state that, like I said, all this sounds good. I can hear all the different points and everything that you sound like you're going to cover and everything, and it sounds amazing, but it just kind of also sounds impossible because I've been, like I said, to 5 different programs. I'm excited that, this is going to, out because there is a need for it. Again, like I said, being in the project plan was, I feel like the most important thing after have to go back to the sick environment. And so, program it's really important because you have to learn how to learn how to get up and go to work. You have to have structure, and I've seen where go from here to that kind of thing. Any areas there, I did finally, started, I did I guess a halfway house. They had a program set up through, they called it Deal. They did a partnership through, Goodyear Tire in Lawton. So we got to stay in the halfway house and then give us, wherever, you go work wherever you want to, but it was a recovery-based work program that we were able to go to. So like I said, I just want to say that the aftercare is, is very vital, for our part. A lot of times people don't make that choice to go to treatment. They're kind of forced to go, so a lot of times they've got, legal issues as well, that become barriers, so again, to me, I just want to say that, the aftercare, is, like, we have to relearn how to do everything, and to take that extra 6 months to a year in aftercare program, I can almost guarantee that, like I said, the success rate is going to be, really a lot more success. Thank you.
No problem. I greatly appreciate you sharing that. No, that was all excellent points, and I greatly appreciate you also sharing your story of recovery. And just to expand on that, you are absolutely right. Treatment is not, I'm going to go someplace for 28 days and it's going to be over with, or even finishing up with an intensive outpatient program as folks go through that continuum of care. It really is a long-term piece, and very similar, Brian has been talking as we've been working closely on this project together, is we have to develop the aftercare process for folks too. And a lot of times, and speaking as a counselor myself and doing treatment for a long time, what should happen, is supposed to happen, is somebody comes into treatment, we're planning what the aftercare looks like. Where is the community, what's the living situation, what's the sober living support, so on and so forth, that the person's going back into in their community, because it's crucial. Otherwise, it goes back, as you said, in the same treatment environment, which can lead to relapse, unfortunately, without the right supports in place. One thing that I really like about this facility, at least for those here in the local community, is being able to try to get in aftercare supports, bringing in self-help meetings and what that looks like. And I would love to, I saw some, it was the Swinomish tribe out in Arlington area, not Arlington, but Anacortes, Washington, where they had an opioid treatment program that had the full continuum of care, and they had housing out there too, which was amazing for folks that would go through the treatment program and then housing to get on their feet and reintegrate back into the community. So excellent point. I appreciate you sharing it, and I appreciate you sharing your story of recovery. Thank you.
Here, I'm going to have you do it on the microphone so people online can hear it.
Yeah, I did see the layout and how they're, because I also work at a sober living house, and we have next door is the rehab. It is we have learned that it's not very good to like have them mingle, the inpatient and the ones who are transitioning out. But I did see that they were kind of all under one roof, which that is kind of hard to keep them, because then there could be like fraternizing and stuff like that, and don't want to endanger anybody's recovery and to give them a chance. And just intermingling all them together with the detox would be hard and very different. Along because I did see also non-natives and natives together, and you're teaching traditional medicines. That was just one thing that I noticed.
I have a question. I know you were saying like having the state involved is going to create access to treatment, but how is having the state involved going to make it easier to access treatment? I think for people who have been to treatment, myself included, my own lived experience, it's kind of when you're ready to go, you're ready to go. So are you going to have to be like in crisis and then go through the crisis process to actually get into inpatient, or is having the state involved going to make it easier? Because it's still a process. Like you still have to have like all of these ducks in rows. Is it going to kind of be like a one-stop shop? Like they can come in, they can get the required testing that they need, they can get all of this stuff in place. So I just I've never been to like a state treatment facility, so I don't know what that looks like, but I have been to tribal facilities, and I know even there it's a process too.
No, it's an excellent question, and I can't remember the context of which the state come up. What I can say to address it is, there'll be several doorways into treatment, so it's not necessarily for folks that are involuntarily put into treatment. Certainly we'll have the capacity for folks that, may be involuntarily going to treatment, but we'll also be able to serve those that are voluntarily that want to come to treatment. And as they come in, folks will be assessed, and they may need outpatient services. They might not need the acute crisis services. They may not need detox services. They may need a residential stay, or they might need intensive outpatient or outpatient treatment. So really, there is no necessarily wrong doorway. You have to go into the crisis services to do the 28-day program. A person can come in at that level 1 outpatient, if that makes sense. And as we know, and addiction treatment, I might come into outpatient services and then 3 months later relapse and something happens and I do need those residential services. And really that continuum of care, did I answer your question? Does that make sense?
Yeah, I was just wondering if I were to be like, okay, I want to go to treatment, I know that this isn't just the I've seen in our community and going to get help and then they have to wait. And then when they have to wait, then
Yep. And having worked in outpatient treatment for many years and beaten my head against the wall of trying to get people into treatment that are ready, strike while the iron is hot, I'm ready for treatment, and then you do the assessment, and then there's no beds. Or you get folks to detox, and they've detoxed, and they're ready for the residential portion, but there are no beds to transition, and they go back out and relapse. And, it has can be an incredibly frustrating process navigating the treatment. The hope as we were developing this really continuum of care, putting detox and residential together so they weren't two different programs, two different systems, would be able to serve those that did need a detox could go straight into residential without having a gap in service, because I see we lose a lot of people to those. But you are right, there's certainly capacity issues, and if it's a full house, what do you do with folks? I mean, there is no additional beds. My hope as we develop the clinical programming is to create low barrier access as much as possible, being able to come in, have an assessment done. We don't have any beds, so if we don't have a bed, where can we get them to someplace that needs it, and being able to get them as soon as possible and helping coordinate that care, and even being able to transport. That would be my ideal if we wouldn't be able to serve that need. How can we get them to someplace that could? And so somebody could walk in the door and say, I need treatment, I need help. Okay, let's get them connected with a counselor, let's get them in and get an assessment, and what do we need to do to find out where they're at, what their treatment needs are. Good point, good question.
Thank you. This is President Echohawk. I just wanted to add to the aftercare issue that was raised. And of course, I'm not a medical practitioner or expert in any way, but I do get the feeling that the aftercare portion, as well as the reintegration back into the community aspect, is a very, very critical piece of treatment. And I would just say to that I have been intrigued for some time now about the idea of tiny homes, possibly for use for that purpose, maybe a half a dozen of them, or some located somewhere near the facility on the tribal reserve. And I believe that the nation could use them for multiple purposes, including the aftercare and the reintegration. And so I was just wondering what your thoughts are on that, because we are at the planning stage. In your experience, what do you think about the use of these tiny homes, as part of an aftercare or reintegration program? And if that seems to have merit, do we have the latitude to include that in our planning?
And I apologize for using one mic. We're upgrading our system, so I apologize. We'll have better mics next time.
I will say that I don't have enough experience in working with tiny homes. I know of programs that have done it. As I mentioned, the Swinomish, we're going to incorporate housing into it. What I'm more familiar with and have seen is more sober living homes, and I think the young lady had talked about working or being part of a sober living home. And really what that is typically a home type of environment with roommates, folks that are in early recovery. There's typically a house manager to help oversee the process, and it's getting set up. They might go to treatment during the daytime, or they might be going to work and reintegrating back in, and there's some accountability there too. And you could probably explain it better than I can, because I don't work at a sober living home. But I find that those, not that it wouldn't, because I've worked with a lot of folks who are homeless, so they come into residential treatment and they have no place to go to afterwards. We refer to an intensive outpatient to follow up, but I'm camping out in the woods in a tent, and so I think for that segment that have no housing, it could potentially be helpful. But we also find that the sober living model works pretty good, and have worked really closely at building those around treatment programs, if that makes sense.
Getting my exercise today. My name is Jennifer, and I work for the tribe, and I have a question just on behalf of, I think, a lot of families. My family is a representation, I think, of a lot of Native families. In the state of Oklahoma, there are more Natives in prison than all the continents on the globe. So I would like to see if there's going to be any kind of post-incarceration syndrome, PTSD, for ex-offenders coming out, as well as with their families for support for reintegration. My family is an example of that, and I think a lot of families have that, but they don't talk about it. And that's something that's not evidence-based, because no one talks about it. People don't talk about the dark underbelly of society. I hope that this facility will talk about real issues and really bring things up that others don't. So I just wanted to say that.
No, and I appreciate you mentioning that. I'm not working on the project. I know Ascension is currently working with a state and their judicial system for a reintegration program for folks, as you were kind of just describing, transitioning out from incarceration back out in the community, which is a huge risk. That's a high-risk population and all the things that sort of come around that, too. So, no, I think that's an important piece. We want to make sure that folks that are transitioning out of the criminal justice system, they have the supports around them, because if they did have substance use issues, typically those have been suspended during incarceration. They come back out, and it can. And high risk of overdose and death and all the things that come with. So the very, very high-risk population as they transition out. We used to prioritize that population and get them in, if we can identify them. The challenges sometimes have been is working with the judicial system to let us know when folks, and so oftentimes it takes really a partnership with the judicial system to let us know when folks are being released so we can coordinate care, so we can make sure it's a seamless transition. So, no, thank you for mentioning.
I'm Molly Trantham. I'm a nurse here in Pawnee. I've lived here pretty much all my life. But the last 3 years, I've been traveling doing agency nursing to Tulsa and surrounding areas, working in a crisis unit, detox, and a unit like that, like a recovery center, that does transfer them over to outpatient services. And I've also worked in rehabs over in Tulsa. But I wanted to say about the aftercare situation, one of our biggest things that we continue to see frequent flyers come in all the time is missed appointments afterwards. And I know that the tiny homes, I think, is a great idea, but you also have to think about the ones that are living 20, 30 minutes away from here. The biggest thing was they would be set up for outpatient care. They'd go once, and then they'd miss the next appointment. And their biggest reason was, I didn't have any money to get to the appointment. I didn't have any way to get to the appointment. I think that if we think about something like that, like I know case managers over at the place that I worked would go out and sometimes bring patients into the facility for their outpatient appointment. I think that was really great, because a lot of those people, they wouldn't come without someone being there to help them get there, because that's the biggest issue. I mean, and I don't know, I couldn't really see the structure of everything. She pointed out how, like, the detox and the residential are right next to each other. I'm assuming those are through a locked door, correct? And then I couldn't see if there were bathrooms in each detox room or not. From my experience, it's a bad idea. A lot of these people are going through crisis, and when they're detoxing, they aren't in their right mind, and they are a big suicide risk at that point. In the places that I've worked before, bathrooms are kind of a dangerous thing. We watch people go into the bathroom. They have to knock on the door to get in. We watch them go in. We wait and see how long they're in there, because they're not in their right mind. They're a risk for their own safety. So I just kind of wanted to point that out as a thought. I think that's it. Thank you.
No, thank you for sharing that. All good points, too. And, we have thought in terms of the bathroom pieces is that everything will be anti-ligature on both the residential detox and crisis side. So they do have, all the rooms have their own bathrooms, and making sure that that they're safe for folks that go into. And part of that's the requirements for the type of facility that this will be, that they're going to require that that's anti-ligature. That was the second part, and did you have another question on that? Sorry, I missed the first part of that, so that's. Thank you, and my brain sometimes skips 3 steps ahead, and what I was going to say to that too is, and this is, Brian had brought this up, is transportation and looking at that. You know, so as folks coming into outpatient, that's going to be huge in terms of being able to get people to services, you know, because I'm 20 miles out, I don't have transportation, I don't have gas money, don't have, and how am I going to engage in treatment? And so I think that's going to have to be a big component to be able to get folks to and from treatment. We have not looked at that, but it's certainly, we are open to ideas, and that's part of what today is really to kind of present and get ideas for things to look at. And so we are open to all ideas and possibilities, so. Was that you, Brian, or? No, that's definitely a good point. So, yeah, that's something for consideration too, so. Any other questions or comments?
One of the questions was that not everyone is suffering from substance abuse disorder, but they may be having the mental health issues. So how is that going to be addressed with a facility of those just suffering from the mental health issues? And the other question I have was, what collaborative efforts have been made with like the local tribal substance abuse program and also surrounding tribal substance abuse programs in like the design of the building and also just the need as well as the curriculum? Like how is that going to be different? So I guess those are the 2 questions.
So in terms of the curriculum, we haven't even started that process yet. We've kind of talked about the services that we're going to provide, but really that's, as we were kind of talking about during the construction phase and the program development, we'll start getting into that. The engaging the community and talking about local treatment services, you know, we've been working closely with Mike and his program here in the prevention services and identifying where the treatment gaps are and looking at the treatment needs and incorporating his feedback and looking at, you know, what can we provide, can we not provide. Not that I'm aware of. Brian may have reached out to other treatment programs outside of Pawnee. I don't know if we have or haven't coordinated that. I don't think we're at that step of the project yet, if that makes sense. And the second, what was the first question?
About some people that are suffering from like mental health issues and not suffering from substance abuse.
It's a good question. So pretty much the majority of the facility and the facility services will be designed for folks with substance use disorder or with substance use disorder and mental health issues or co-occurring issues. For folks with just mental health issues, should be able to access the crisis unit for crisis stabilization, but really the detox and the substance use disorder residential facility won't be designed for folks with just mental health issues. And neither will the outpatient program. The outpatient program is primarily going to be designed for folks struggling with substance use disorder and or co-occurring mental health issues. Any other questions or comments? I know we're 10 after. Sure. When you say phase plan, what are you thinking? Thank you for elaborating. So we are looking at, and it's probably about 5 slides ahead that we haven't gotten to, sort of future expansion services. In terms of, we would probably expand the outpatient services. Residential services would take an additional CON, and certainly if the need was there, we could explore that and look at expanding those services as well. We haven't really talked about increasing the bed capacity. You know, I mean, we have, but and it has, we have looked at that, not on the inpatient unit sides, it's the outpatient wings that we've talked about expanding into services, getting more into mental health outpatient services, psychiatric med management, child and family services, and incorporating those in, even having child care for folks while they're participating in treatment. Oftentimes we see, I'm coming to substance use disorder counseling, I'm coming to this group for the next 2 hours, but I don't have anybody to watch my child. And being able to have that as well. So those are some of the next phases that we've been looking at and expanding on that.
And also I'll elaborate, you know, if you look at the design of the facility, it does incorporate expansion, you know. So when we look at, you know, the outpatient wing side of it as well as the inpatient, it does require, when you work with the state, is, you know, solidifying those beds. So right now on the CON, we're just only got 26. We believe that there will be a huge demand and we will need more beds, but it is phased out where, you know, we could expand out, and the property that we selected, we can build outwards if we wanted to have more beds, but it will be a process. So through our phasing, yes, the way that the building is designed it makes it applicable to have expansions while we start looking at future development. So we've thought about it, not just from a service standpoint, but the design phase does incorporate where we could expand on the inpatient and outpatient side of things. Well, is there any more questions? If so when we do look at our outpatient and inpatient, it will be, once we open up the door, I mean, that's where the evaluation is going to start. So based off of the need, once we start providing those services, we'll strive us of looking, yes, building the outpatient and inpatient.
That's correct. You know, we had talked about that, and right now it's not on the table. The goal and the plan is to build it, and then we will start the outpatient and residential services simultaneously. Of course, that could change staffing issues and things that may come up and phase it in, but that's not the intention as of now.
Our plan is, we've been working with Mike Ortiz, so the plan is incorporating our substance abuse programs into this facility. So it could be a hybrid where some of the folks are over at the new facility and we can utilize where they're at now. So we're still working with Mike and figure out, you know, if there's a hybrid system where like, hey, some guys can move over and, you know, definitely look at the outpatient. And then if there's additional services that we see that is a need, you know, we can utilize the facilities that they're occupying now. So, but yes, we were looking at integrating them over.
Any other questions or comments? This is good. I like that people are asking questions and putting out suggestions. This is exactly what we were wanting for today, too. So very, very helpful. Sure. So we have talked about that. In fact, we had that discussion last week as far as creating a airborne isolation room. And right now it is in the current design to have at least one room that is fitted for airborne isolation. So I'd love to have it in all the rooms to have the capacity to be able to do it, but I don't think we'll be able to do that. But in those certain cases where being able to do it, to be able to manage it. I will say a caveat with that, though, is it's not a medical hospital either, so for those that have more acute medical needs that presenting as there being that, they may have to go to more medical hospital stabilization before they could come to our facility, if that makes sense. So there may be those folks that we would not be able to serve because of acute medical, if that makes sense. Any other questions? You know,
right now we're recruiting folks, so we haven't, I know we got a meeting next week with council to start looking at individual folks, and we'll reach out to them and see if they're interested. So right now, currently, we are recruiting. We haven't selected, so I'm thinking within the next couple of weeks, we would select of individuals that are interested in being our board members. So we don't have a set timeline, but we think in the next couple of weeks. Well, our qualifications, it vary. You know, we definitely want individual folks that are familiar with this background, you know, because we want to make sure that the board, yeah, I mean, yes, she would be adequate individuals, or just individuals that don't have the, let's say, education, but are familiar with the processes, that been through the process. So we don't look at, let's say, a degree behind their name or initials behind their name, but we also want to know people that are familiar with the processes if they've went through that. So, I mean, we're open. We don't really have a criteria of what we're looking at, but we just wanted to definitely want individuals that are knowledgeable about the process. Yes. Chris Lee. Mm-hmm. Yeah, Doug Leach is a prime example of folks that we're looking at. I mean, what he's done and created, I mean, is remarkable, and that's what we're trying to mirror here from I guess, a native perspective. But yes, I mean, you don't have to have the education, but if you've been through the process and done that, I mean, those are, yeah, so, but again, if you're interested, anyone that's here or virtual that interested in being a board member, please reach out to me. You can leave. We got a Dropbox in the back. You can provide your information. But so right now we are recruiting. So we haven't just selected just yet. Any more questions, comments? What we'll do right now, we're going to take a little break right now. We got lunch provided in the back. Get y'all, we'll probably have a working lunch, but we'll take about a 15, 20-minute break, allow people to go to the restroom and things like that. In the meantime, the people that are virtual, please, we see your comments. We're going to get to them at the end of the day. So I just don't want you to think that we're ignoring you, because I got them sitting on my phone right now. So we'll make sure that we address all the questions that people are putting in the comments. But just in the meantime, we'll just take a 15, 20-minute break, allow folks here, grab a bite to eat, and we'll continue moving forward. Sound good? All right. Thank you. any additional input. Again, feel free, we got a Dropbox. If you don't want to open up in public, feel free to write any questions, concerns, or whatever. We got it on the note cards, and we got a Dropbox. You can feel free to drop them off. Continuing with people online, we see our questions. I think a lot of the questions that have been posted already we're about to get into, but feel free to continue writing comments and things like that on Facebook, and we'll make sure that we get your questions, concerns, or any additional input that you're looking for. We'll make sure that we address it. But we'll go ahead and start. Again, thank you all for being here, virtually and in person. I think this is a great thing that we're doing here. We believe it will have multiple ones, so anyone that hasn't been able to make it today, make sure that hopefully y'all can make it next time. So we'll definitely keep engaging with the community so we can make sure that this facility is a top-notch and addresses all the needs in the community. So I'm going to pass it off to Chris so he can just kind of top-notch this last slide, and then we'll move forward.
Thank you, Brian. I appreciate everybody hanging with us, and hopefully nobody will fall asleep after getting a full belly, and listen to my voice put you to sleep too, so we'll try to keep it pretty engaging. And I appreciate the questions and comments so far. I think that's been really helpful and keeping us on our toes and really making us think and providing feedback too, and that's exactly what we want. I kind of want to continue to expand. We've had this slide up kind of talking about services. We haven't entered the program development phase really yet. As we've been working on designing the facility and looking at the floor plan and the layout and working with the architect, we kind of outlined and talking with the community what services that we feel there's a need for. Certainly this could evolve, and as we go through that program development process, we're going to start expanding that out and get more specific as far as treatment schedules, different types of tracks that we want for individuals participating in, whether it's in residential treatment or outpatient treatment. So that's still in development as well too. So I just want to kind of break some of this down a little bit. We talked about traditional medicine and incorporating that in to both the residential and outpatient program, and that would be integrating traditional services such as sweats and talking circles. White Bison, when I was working with Seattle Indian Health Board and developing their intensive outpatient program, used Western medicine and also integrated the traditional practices too. And they also both served natives and non-natives and created tracks where a lot of non-natives would still participate in the traditional practices and get a lot of benefit out of it too. But we'll have different tracks that are developed out and really tailored to the individual seeking treatment and what they're looking for too and want to get out of it as well. So we will be working with the traditional healer to work really in close collaboration with the treatment team, the substance use disorder counselors, case managers, clinical social workers, as they're going through the recovery process. Talking about the adult residential program, I think some of our questions got a little bit into this, but defining that out more, we'll have the crisis stabilization, and that's really for those that have more acute psychiatric needs. Those might be involuntary folks that are a risk to themselves and need that stabilization process. And it would be built for those that have both co-occurring just mental health and or mental health and or substance use disorders. We'll have the withdrawal management that we talked about, or detox. We'll have two different detox levels of care. One is more like what they call social detox, and more is the hospital level detox. There will be some folks that may need more biomedical services that I mentioned earlier that are in more that higher level hospitalization detox that might have to go to a hospital first, just depending on how they assess that too. But we'll be providing that service for those folks that are physically dependent on substances and are coming off of substances and going through the withdrawal process. We'll have the residential treatment, and I hate to get away from or sticking with sort of the key words. Typically people refer to them as like a 28-day program. Really, that's not enough. That's 28 days. Things are just getting started for folks, but that's typically what we see for residential programs. I see your hand raised. Do you want to? And we should be able to. I haven't asked Brian for folks that are interested in getting a copy of this PowerPoint too. If folks are interested, we can give contact information so you can see this. But typically refer to it as a 28-day program. Sometimes folks need services for longer than that, sometimes shorter than that. We will have co-occurring tracks for participants that struggle with substance use disorder, so it won't be just substance use disorder only. And then typically once somebody completes residential treatment, so there's been a lot of discussion about aftercare, and aftercare, depending on where you're at in the continuum, can look like a lot of different. If you're in residential treatment, typically the aftercare is, hopefully I'm going to an outpatient program afterwards as I'm integrating back out in the community as well as community activities. So really coordinating that with our outpatient program, and if they're not from this local community, then being able to coordinate with their local community to help make sure that they've got those services in place.
In regards to the, some of the treatment programs or the programs that we're using, my name is Pawnee Horsechief, and I'm a Pawnee tribal member here. And being in recovery myself, one of the things that, and doing community work as well with the white bison model, which I would like to see like us developing our own model with our own knowledge that we have, with our Nasharo Council, and the ceremonial that we have, that it could be beneficial. You know, we're in the process of, I just got back from White Shield, North Dakota, from visiting the Arikaros, and they have, Jasper Youngbear is developing his own, so to speak, cultural for co-occurring disorders, and that's addiction and mental health, and so I would like to, my input is that to develop something our own, and use our Nasharo chiefs and our council and our elders that we have, and developing our own program. And that's something that would need timeline, would need to start like ASAP. But we have a Nasharo council that meets, I believe, on a regular basis, and that's something that we could put before them and their board to start progressing that, because I think that in learning and participating in White Bison myself, they have online programs, which we did during COVID on Thursday evenings, meeting Zoom, and that's something that we could develop ourselves with our own substance abuse program. Developing those, and then our own sweats. I was just looking at the things that I caught notes of. You know, we're building our own Earth Lodge. We could develop our own. Our substance abuse program is doing really well, and doing sweats over there else already. But I think that big picture-wise, if we could not use like an overall canvas of different ways of healing, such as White Bison, that we could bring it down to a smaller scale and to where it's more for like our region, because these are different regions where they're dealing with. If you read the White Bison, then you're not dealing with like Oklahoma regions and healing. So, and then also with following up with the program, I don't want to do like something that hopefully the aftercare, hopefully that they'll follow up with their tribes, and that's developing a system to where there are tribes that there's already a system developed for after follow-up care, because us hoping isn't what has, that's what's failed us as people in addiction. We can hope to follow up, but if we set up like a mainstream, overall big picture where their aftercare follows up with healing and family integrated in that, and culture integrated into that, maybe they could see more into the whole big picture, because, and that's not just on you personally, that's just the wide wrestling with civilization and rehabilitation, is that we hope for follow-up aftercare. Now, we need this for our people because they're dying by the numbers, whether it's addiction, alcohol poisoning, whether it's suicide. It's something that we can hopefully be about. So let's develop a system to where that's more mainstreamed towards our people here in this region. More towards, we're looking at Pawnees. I know it's for overall, but I'd just like to share that input. Thank you.
Thank you for sharing all that and mentioning the white bison. And that is definitely something that we'll be looking into. I'm actually working on outlining sort of the roadmap and business plan, and mentioned white bison. When I worked with Seattle Indian Health Board, they integrated white bison, and we're bringing that into their outpatient program. And we're looking at it and exploring it, and I think it would be, I love the idea of being able to create their own program that is unique to this model of care here too. So I think the sky's the limit.
Right, because there's a professor that Ryan Kirk is next with, Dr. Pawnee. He's already had the system, Ryan, and he'll agree with me with that. He's seen it to be developed for modeling cultural, co-occurring model of healing. Dr. Pawnee Randall, he's at the, at the time he was in the president and for Retreat Nation Hall. So he puts a study, use this program to develop this study through some of his students that he taught in the 90s program. It'll be interesting to hear the results of that. Ryan Kirk can speak to that.
I love it. Everything that you're talking about, I absolutely love it. Sounds like you're interested in helping develop that too. So it's.
You know, because I'm tired of seeing my people die by the wayside, my family as well. And I'm included in that.
Well, I appreciate your compassion and your commitment to it too. And if you're interested in participating in helping develop what that looks like, we're certainly looking for input from individuals that are. So thank you. Any other comments or questions before I kind of jump back in? Okay. Looking at outpatient services, and we talked a little, I kind of outlined this. This is just sort of a generalization. So intensive outpatient treatment, it can be anywhere from about 9 to 15 hours of treatment per week. Typically, we see an intensive outpatient 9 hours a week, and that's primarily group counseling. Individual come 3 days a week for 3-hour groups, as well as individual counseling. Of course, the way that model of care, it can be really broken up to more or less, depending on what the individual needs, and can create different tracks. But typically, it's the 9 hours a week. Outpatient treatment is the level of care below that, and that can be anywhere from 2 to 6 hours a group and individual counseling per week. And again, the tracks are really tailored to what the individual's needs are, as well as the intensity of what that looks like. And the levels of care really can be tailored to meet what the needs are. We will include youth outpatient programs for adolescents between the ages of 12 and 17. That's including outpatient treatment and intensive outpatient treatment. We'll also have the adult program for folks that are 18 and up. We'll make sure that there's access to medication-assisted treatment for folks that struggle with opioid use disorder and alcohol use disorder. I think I may have mentioned it earlier. A lot of times people don't look at medications for alcohol, but there's good medications out there too as well to consider. We will have co-occurring tracks for those that struggle with co-occurring mental health and substance use disorder. And we'll look at evening programming too for folks that work. Sometimes that can be a barrier to participating in treatment. Groups are only offered during daytime. Well, I work during the daytime, so being able to have after-hours access to treatment services. And I think I mentioned earlier in the presentation, making sure that we have space for self-help groups and community activities outside of the outpatient clinic for folks to participate in, such as NA and AA and Smart Recovery. Any questions on the services kind of provided, or any? You know, we talked a little bit about this earlier too, before lunch, is the potential expansion for future services. You know, these were sort of, these were actually in the original design, but as we've looked at, you know, with the primary need, those services that we just went over, we identified as the primary need, but these are definitely services that we would like to incorporate sort of in phase 2, which would include outpatient mental health counseling, as well as psychiatric medication management. We'll have that for the inpatient portion, but not for the outpatient portion. We'll be working with IHS across the street to really coordinate those services, but it would be nice to be able to provide that and add that to our outpatient clinic as well. Looking at child and family counseling services, and I mentioned, I think, child care earlier for those participating in treatment. And, you know, haven't really dug into it enough yet if it would be helpful or not. or even if it's a service that's available in the state, is partial hospitalization services. And for those that aren't familiar with partial hospitalization, it's a really intensive program for folks that are transitioning out of inpatient to outpatient. I mean, it's really intensive. It's about 20 hours of group therapy a week. You know, oftentimes we'll meet 5 days a week for 4 hours or more. So it's really structured, and that may be something that we look at too as well. On the partial hospitalization? For the existing program, the plan is to work with IHS for folks that need mental health counseling. I'm sure we'll identify other third-party folks to be able to assist with that too as well. What's that? I'm sorry. No, we haven't gotten that far into it yet. So certainly open if there's folks that'll be a part of it as we start the program development and being able to identify who our community stakeholders are, folks that we'll be able to coordinate those services with and work closely with. So when the facility initially opens, it will not have just solo mental health counseling and a mental health outpatient program. It'll be substance use disorder counseling, individual and group, and those that do have co-occurring issues. The hope and plan is to eventually add that on. It won't be in the first phase when the program opens up, though. It could be. It could get thrown in the mix. Folks could say, no, we need mental health services there available, and we could look at putting additional resources to that if we feel that it's a need. Yeah, and I heard a lot of that too when I was talking with folks in the community, that it was really that IHS provides mental health counseling, but it takes time to get into that process, and folks, they need more services available. Did I answer your question? Any other questions or comments on that? You know, the staffing right now, I think I looked at the recent staffing model. We've got about 53 employees. There's some additional folks to contract with. It would include the traditional healer, psychiatrist, who would be the medical director, a team of registered nurses who would oversee the residential portion, clinical social workers and counselors, you know, peer recovery supports professionals that we've talked about for folks that are in recovery and being a part of both outpatient and the inpatient services. Behavioral health technicians are really important for the residential services, case managers, and of course administrative staff and dietary staff and maintenance folks. Regulation, go ahead. You know, it's been mentioned, we haven't talked about, we haven't put it in the staffing, and it's not out of the question, but it just hasn't been mentioned or put in there, so. Oh, sorry.
Can you say what the question was?
So the question is if there was any plan to have any security that was going to be at the site or facility.
So the places that I've worked before, they have the nurses and the recovery coaches trained in certain holds for these residents that will be there. But it's also very important to have security there as well, because, you know, some of these people are, when they're withdrawing or just not in their right state of mind in a psychosis or something, they're very strong, and if they're there involuntarily, like, I mean, I think that security is a important part of that, because sometimes we can't always hold them down by ourselves. And that's like kind of like the dark side of it, you know, to be honest. And another question is, are you only hiring registered nurses, or are you going to be hiring LPNs as well?
In terms of the nurses, we may add LPNs. I actually had it on the original staffing model. The type of facility requires a ratio of the RNs, and that's where we created it, the staffing model. And I think you can utilize LPNs if you go down between a certain number. It gets really interesting in terms of the ranges of the staffing ratio per patient ratio, and when you can have an LPN versus an RN. Based on our capacity at 26, it looked at we're going to have RNs in this amount of staff, but it certainly wouldn't be out of the question to have LPNs, I think, just depending on that. But I'd say the majority are going to be probably RNs. And I think that's a good point as far as security, as we've really gotten into the program development portion of looking at that, and the type of facility, and, you know, what do holds look like, ideally want to try to avoid restraints if at all possible, and there's been a lot of discussion. We'd like to stay away from doing any restraints if possible. I don't know that that's going to be possible at this type of facility, and so we're in those discussions right now about what that looks like too. So, but we've got a good while as we go through our program development process to look at that and work on that. But no, that's a good point. I appreciate that. Well, and a couple of ways to answer that. So it sounds like the question is who is helping direct and provide input on some of those decision-making processes. And so I'd say that's multi-layered. At the core of the program development, we have our team at Ascension Recovery Services, who the vast majority of our folks are in recovery and have been through treatment and gone through various levels of treatment. So we do have some input there. We're also working closely with contacts at Pawnee Nation, Brian and myself. And really, that's part of the purpose of what we were here today. And I'm kind of jumping ahead 4 slides, but being able to identify folks from the community and being able to provide input into the program for things we might be missing, for not being able to, what is it that we're not looking at, and being able to provide that input and incorporate it in, I think, is a vital component to it. So. The good stuff, regulations and oversight, and talking about that. And, a lot of folks look at the facility, regulate the facility. I'm not going to spend too much time on that. Just there's a lot of rules and policies and procedures and folks that we have to follow, including from the State Department of Health. This will be an accredited facility going through Joint Commission. Our facility standards, a lot will be outlined by the State Department of Health, Joint Commission, Centers for Medicare Services, as well as Indian Health Services. Our staff will be trained and supervised, working closely with the psychiatric provider and working closely with the medical director and the nurse director of the facility, as well as the clinical director. And I think I've already kind of talked about this. It was one of the questions that came up earlier. As folks come into the treatment program, they will go through a screening and assessment sort of to determine what that level of care is that they need, and if they're appropriate for this type of treatment program, and if they're not appropriate for this type of treatment program, how can we get them to where they need to be and get the right services and connect them with that treatment, I think is crucial. So, yeah. And this, I'll hand it over to you, Brian, to kind of talk about that community engagement piece.
So one of the biggest things that we're here for is to get community input. So what we also want to do is develop a advisory committee. You know, what we're looking at is we're recruiting folks right now from the Pawnee community as well as surrounding areas to be a advocate for not only for people that you have experience with this, or if it's, you know, yourself as an individual, but, you know, what we want to make sure that we incorporate is programs that benefit directly to the people that are going to come through these programs. So what we're looking at, I know for several months through Facebook, we've put things out there in recruiting. We're still recruiting because we want to have a good advisory committee to help us develop the structures that are needed for the programs that we want to implement. So anyone that's here today or virtually, you know, please, my contact's up above. Email me, call me, or just come by my office. We definitely want to get a good, solid committee, so when we're looking at the program development, which is going to be during the construction side of it, so when you're starting to see the construction going on, there's still going to be work going on behind the scenes, and that's going to be the program development and the services that we're going to provide. You know, going back, you know, this whole project since 2018 has been a community-driven project. You know, when we originally started this feasibility, we did surveys, focus groups. Man, we've been continuously engaging the community because I've heard vocally, you know, the things that y'all are talking about is definitely a need, and we want to continue making sure that the services we provide address those needs. But at the same time, we want to make sure that, you know, the facility from a design standpoint don't have trigger elements to it. We want to make sure it's a welcoming facility. It has that warming feeling. Like if it's not you experiencing, but you run across someone that's needing help, we want you to proudly speak and be like, you want to go to that Pawnee Nation behavioral health facility. They're top notch, and they will get you the help that you need. So we definitely looking not only from a program standpoint, but also a design standpoint. We haven't started yet. We've been kind of brainstorming, is looking at an art competition and integrate, because a lot of these folks that deal with substance abuse and mental health, they're artists. You know, we want to integrate and put their art inside this facility. So we haven't done it yet, but we just kind of been talking behind the scenes of making sure that, you know, this facility has not only a community input, but, you know, has that input to make sure that we provide adequate services. So those are big things that we want to make sure, but at the same time, you know, we can market on our end, but really the marketing is going to be the community people, you know, and getting that word of mouth and speaking on behalf of this facility when people are looking for access or just want to know more about the services that we provide is really going to be the community talking about it. I mean, that's the biggest aspect of this, and that's why we want to make sure that we engage with the community, not only from a service standpoint, but, you know, just one of those things that when you run across a family or friend that's looking for access to care, you know, you can refer them over to us, as well as our stakeholders. We're going to be working directly with IHS, our surrounding tribes, as well as our health providers here in the community, because, you know, we can't, at the first phase, we can't do everything, but it's going to be all of us working together and making sure that we share resources, refer out directly, indirectly, and that's going to be what's going to make sure that we address the need. And then we look at long-term. We want to make sure when they go through our processes and we put them back in an environment, they still have the resources available and the connections that they have to continue that prosperity that they're trying to reach as they further go along through their process. So we want to make sure that we have that in place. So, you know, again, my contact's up above. Behind me, you know, again, stop by, call me, email me, because we want to make sure not only that we integrate, you know, and I want to go back kind of like the things that were brought up with the, you know, coming up with the Pawnee way and integrating things from a Native perspective is just, you know, having a way that we can be unique, you know, integrating Native churches or whatever it may be to make sure that we connect to that person, because everybody's different. You know, and that's what we want to be is unique, flexible, because one individual might work and another thing might work for another thing, but we want to have that ability that will connect to that individual to make sure that they, get the help that they need. So that's why I think the community engagement and input is going to be a valuable thing. So, if y'all have any questions regarding that, please let me know, and then we'll continue. Because I think this process is going to take some time. Again, construction is going to run between 12 to 18 months, so we got time. So this ain't going to be probably the first town hall meeting. We'll probably have numerous ones just to make sure that we keep everybody updated, as well as getting different perspectives and input, so we can make sure that we integrate it. I appreciate everybody engaging in this process, because that's one of the things that we wanted to do. So I'm glad we just didn't hear crickets or just me and Chris talking the whole time. So we appreciate all y'all's input. We just want to kind of open it up and see if anybody virtually or in person had any additional questions, concerns. We want to make sure we address those, and if not answer them today, get them answered for y'all. So please, if y'all have any questions, discussions, if you don't want to ask in a public setting like this, feel free again to fill out those note cards and drop them off in the box, and we'll make sure that we can get those answered. Yes.
Here, let me give you the microphone. Also, I'm passing around a sheet. If anybody wants to be on the advisory committee, you can just sign up right now today, and easy peasy.
For myself, one of my greater concerns for the areas is, jobs. I was wondering what kind of jobs, if there was going to be jobs, that would be more job opportunities, if you knew how many jobs it might provide for the community, the facility, when it's up.
So the sheet is just for an advisory committee, right? For people, boots on the ground, who can set the tone of what this should be, what areas we should be working on for Pawnee-centric, on what, just like, talking about not restraints, but security, just, family who's been through it that can help you. That's what you're looking for, right? So not board members, but like peer-to-peer members. Okay. Anybody else have a question?
And that can be tough sometimes. So in terms of the job piece too, the staffing models outlined up there, we're looking at around 53 current full-time employees. It could go higher than that. There's been a lot of discussion and probably work over the next year in terms of workforce development, because where do we get people that are trained to, substance use disorder counselors, behavioral techs, and we've talked about how do we create programs at the local college level to be able to train folks that might be interested in these types of programs. So really connecting with the schools of education here around to be able to create some workforce training opportunities for folks that might be interested in getting into behavioral health too. So I'm kind of excited about that component. So I think there could be opportunities for workforce development at our school level. And education, and so yeah, does that answer your question?
And outside of indirectly jobs, when we look also at the construction aspect of it, not only we look at the directly jobs here that would be, occupying this facility, but there's going to be many, many more jobs on top of that, because you're looking at engineering, you're looking at electrical, plumbing, construction. I mean, you're looking at several more jobs. I'm thinking almost 100 plus, because unique of this facility and how large it's going to be. I mean, you're going to have many, many jobs. So that's where we take advantage of our services. We look at our education division as well as our tarot, looking at letting them know, hey, we got these jobs coming up in the future. Allow those programs to start the recruiting and the training. So when we get to that point, they already have a job pool created that will just integrate, local individuals to do those type of jobs, if it's just landscaping, construction, whatever it may be. So we believe that it's going to be not only just full-time from directly a facility like this, but indirectly all the other external jobs. And then all the program development services that grow from this facility, because this is just one little aspect. We believe that a lot of our education programs our substance abuse programs and other things will grow and prosper from this too. So that only creates more jobs too. So this is just one movement of this that I think will create a lot of economic development here in the community. So those are just something that I just wanted to highlight, because we do have this above me, behind my head, but just wanted to talk about indirectly all the little jobs that we'll be working and providing as well. So it's going to make a huge economic impact.
And then people have been writing board member suggestions. If you have any names of people that could be board members, write them over here and leave them, and we'll grab them.
My first is just a comment. Well, thank you both for your presentation. I actually was on the initial planning grant for this, so it's really great to see, Brian, you continue working and making it come to life, you know, so I'm really grateful for that and for your hard work, and yours as well. And so I see, which I think people aren't understanding, is with this type of facility, is it's going to open up opportunities for other programs to fill those gaps that we may be seeing as well. I know my concern is the huge gap for housing within our community when we do have these jobs created, just because we see it with our Indian Health Service. You know, our pediatrician travels from Owasso to come to our IHS, you know. So I'm hoping that maybe people listening online or even in the community right now are know that there is a huge need for housing within this community for people to come in and work here as well. So maybe that's an opportunity for funding to build housing for workers. And my other question was about the regulations and stuff, and again, it goes back to having the state involved, is just how is that going to impact indigenous practices? And I really wish you guys would reword some of this stuff. Like, the wording's important. So when you say traditional Indian medicine, that just looks like a colonized term, and like, oh, I can go here and get me an Indian name. Like, that's how I see it. So maybe trying to reword that and reframe that differently. But just how is those kind of state regs, like, is it going to have an impact on how we can introduce, you know, traditional indigenous knowledge and practices in the facility?
And then I have another question back there.
So on a regulation standpoint, what's unique is more on the regulatory oversight. It's more on the reimbursement stuff of it. We have the unique standpoint to provide those services. So we don't have restrictions of, you know, native customs and things like that we can integrate. So it will not impact that at all. You know, that's why we want to make sure, because we're going to be serving not only just Pawnees, probably other people that want to learn the process, but, you know, there's other things like, you know, myself being part of Watermead, you know, we integrate the medicine wheel. You know, we do a lot of 4 grasses, which I know the Pawnees are more just the cedar, but, you know, we integrate all 4 grasses. But we want to make sure that we want to integrate, you know, multiple different spectrums that, you know, again, it's going to be client-based. So we just want to have that opportunity to make sure that they reach the need that they need so they can reach prosperity. So it's not going to have any impact. More of it's just through the licensing, the reimbursement rate, and things like that. We make sure that we can have a sustainability mechanism in place, so when we go back and look at the reimbursement rates and things like that, we can bill for those. But on the programmatic side of it, it's not going to have any input or impact. So we'll definitely, I think that's where the community engagement is going to play, because we just want to make sure that we do offer those services. But on that standpoint, it's just making sure that we have, you know, the necessary staff that's required by the state to make sure that, you know, we can go back and get reimbursed for those services, because that's kind of more what they'll, have oversight on, not just the programming.
And I think probably what you were getting at with the verbiage was just changing it more to a native-centric verbiage. So it's true what you said, but maybe make it like intertribal, like use terms that natives use so that it attracts and lets people know it's not a colonialistic or it's a JODICS facility acting like it's native. You know what I mean? So, because the tone's off a little bit.
I just had a question about basically the funding side of it. So when you receive money from various funding sources, there's more regulations and guidelines that you have to follow that a lot of people don't, I guess, understand. So here and there I've kind of seen and heard people basically asking why it's not exclusive to our county or our native population. So I was wondering if you could basically explain why that's not really an option.
I need that thing at the airport that, you can walk on and it.
Well, it goes back to when we started this feasibility study. We know that not all, just like for Pawnees, for example, we know they all don't live here. They might live in Cushing, Tulsa, Stillwater. So we wanted to make sure that we had we wanted to start small. So we wanted to, we started with the 5 county service because we believe that a lot of our folks live more remotely around here, but not directly here in Pawnee. So we wanted to make sure that we kind of broaden our services to make sure, because we know a lot of folks do travel to the IHS clinic that we have here. Not everybody, utilizes it, but, we know that we're rural, so we integrate with other tribes too. We go to other different powwows. They all hang out with different people that are outside of Pawnee. So we want to make sure that we're servicing other tribes, because at the end of the day, they're going to go back to their environment. So we don't want to seclude ourselves saying, hey, we're going to help this one group, but we know all their friends need help too. Well, that's just going to increase their relapse if we're not addressing their friends and family as well. So we wanted to have that, not so much of a broad, but have that opportunity that we can just help everybody possible. Because when you look at integrating an individual back into society, it's not just their internal demons that they're fighting, it's their external. So we got to address the external demons as well and provide those services. So, it's like, hey, it could be a husband, wife, buddies, or whatever. Let's go get the help. And then we're not secluding. It's like, oh, we can take you, but hey, we can't. So we wanted to make sure that we wanted to address everybody. When we look at the funding, yeah, there's restrictions on the funding. There's things that we got to make sure that we incorporate so we can make sure that we spend the funds correctly. A lot of people don't understand when you get federal funding, there are restrictions and regulation and red tape, I guess, basically. So we want to make sure that we follow their policies and procedures, but they also respectfully understand our policies and procedures. So we just make sure that we integrate both of those and make sure that we can utilize those funds correctly, because there is a big compliance component to federal funding as well as state funding. There's always that red tape, but that's why it's important that we make sure that we look, and there's been, since up to this date, I can't tell you how many times we've talked to USDA or EDA, just making sure what's allowable, what's not. But that's just stakeholders working together to make sure that support this project and making sure that we build it. So I hope that answers all your questions. I think there's, but if there's any more, I can answer. It was. And again, feel free to reach out to me if you don't want to ask, here today, or a week down the road, a question might pop up. Again, my contact's above me. Reach out. We're still recruiting folks, so if you know any if you know any individual that might be a great person as well, recommend them as well. I can always reach out to them. But again, let me check online, see if there's any questions. I don't see any new ones.
As Brian searching online, I just want to say, I want to, again, thank folks for coming out today. You know, sometimes going into community presentations, you know, are people going to be for treatment or against treatment coming into the community? And it's been really cool here to hear all the questions, that it's really evident that folks are passionate about treatment and what that looks like for the community. And so anyway, I think that's pretty cool. And so good questions, good thoughts and input, and please keep it coming. And please, as we get this community advisory committee up and going, it's going to be incredibly beneficial, I think, to get input from y'all. So thank you.
Ditto what he says, so thank y'all. I mean, again, I think we'll have some extra food, so if anyone wants to take anything home, feel free. We'll probably kick back a couple minutes, so if y'all want to ask us questions behind the scene, we'll be here for a little bit. But outside of that, again, thank y'all, and have a safe travels home. All right, bye. Okay, so I guess one of the questions was, you know, looking at our competition externally. I guess that was probably something I brought up, was looking at our competition from, I guess that's more like a, not a service, but more of a facility standpoint. So, because what we are building is a lot of our partners will be working together, because again, we can't provide all the services. So a lot of our stakeholders will be referring to folks that we, you know, make sure that they get the services of care that they need, that we can address directly. But at the same time, it's like when you look at the CON, I mean, the state of Oklahoma does look at it from a bed standpoint. So it is competitive because not just like treatment facilities, it's competitive from a nursing home standpoint. In hospitals, it's like, you know, is there a need for beds? And if you can't fill your beds up, they won't open up another facility around you. So it's almost, if you're over served and let's say you got an influx of clients coming in and you can't serve all those, then it's definitely a need. So then another person could come back and open up another facility, or we put in another CON to do an expansion. So it's more on a competitive standpoint or competition standpoint, is just looking at ways that we can work directly with the resources that we have, but at the standpoint, making sure that we develop a model that we're sustainable and we're profitable and we can provide services and jobs here locally. So I think that answered it. Or yeah. So we don't really, I mean, when I talk about competitors and things like that, it's not more of, you know, isolation in a way. It's where we're going to be working directly with folks, you know, not just from other tribes that provide, you know, behavioral health services, but looking at other stakeholders, if that's the city, if that's federal qualified health clinics, IHS, they're all going to be valuable partners in this, because at the end of the day, we all do one job, and that's serve and provide care to individuals. And that's what our ultimate job and goal is. And then if it's services that we can't provide, we want to build those relationships with external stakeholders, so then we can refer folks out to them. So it's just working hand in hand and aligned with our visions and missions of providing that adequate care. So I guess that was just a misinterpretation that I might have spoke upon, but it's not, again, in a competitive way. It's more of a network that we're working together and reaching that ultimate goal of providing good care. Okay. Last time, anyone going once, going twice? All right, thank y'all.
Thank y'all for coming out.